Okay, we're going to go ahead and get started. We got a few folks that have signed in, but obviously you don't have to sign in live on these. We're just doing them at this time. So people that are free are open to watch, but you're welcome to download it and watch these at any time you want. Okay, so we're going to talk today about some tumors of muscle and fat. And there really aren't too terribly many of these that are that important for dermatopathology, which is kind of the good news. So muscle, there's really obviously two types of muscle. There's skeletal muscle and there's smooth muscle. In dermatopathology, we almost never see skeletal muscle lesions. They're almost always smooth muscle. And there's really two main ones that we have to think about. There's like the pilolyomyoma or the erectile tissue lyomyoma, which both look pretty much the same. The latter often from areas like the nipple, the scrotal area, the labial area. And then Angio Lipo, which comes from blood vessels, probably the wall of the blood vessels forms a nodular lesion. I'll show you one of those in a second. And then there's a couple of others, the leiomyosarcoma, which is a smooth muscle malignancy of smooth muscle. And then we have the so-called atypical Lyomyoma, which we'll talk about as an intermediate lesion. So this first one is an example of a just garden variety pilolyomyoma. You see low magnification. There's this pink structure in the dermis. And so this is epithelial differentiation. We're looking at these at low magnification. We say, well, is it epithelial or non-epithelial? Well, this is non-epithelial, obviously, because we're dealing with soft tissue or we're dealing with muscle. And if we go to higher magnification, you can see that they have these small fascicles of cells that are comprised of these cells with these elongated, almost kind of cigar blunt shaped nuclei, often with some perinuclear vacuoles. When you cut those in cross section, you see the vacuoles over here. And the cytoplasm of these cells is usually relatively ample. It's somewhat eosinophilic, like you see here. And it looks pretty much just like a normal garden variety smooth muscle bundle. This may actually be a normal smooth muscle bundle to the side of the leiomyoma. So that's kind of a normal looking, if we didn't have the little leiomyoma to the side, we just saw this is a classic erector pili muscle. Now this actually may be part of the smooth muscle hamartoma here. But anyway, this is a nice example of what normal smooth muscle looks like. And so when you get a lot of those forming a little nodular aggregation like you see here, then we basically call it a leiomyoma. And this is one of the painful tumors of the skin. And these lesions, often when they get cold, they contract. They're painful when they do contract. A lot of times, often when they're not contracting or traumatized or anything, they're not very painful. But when they do contract, probably because of the nerves that are incorporated in this thing, they kind of cause a sensation of pain. So this is one of the lesions in the painful demonic that you need to know. Lyomyoma are also associated with Reed syndrome. So important to remember that, because once again, anytime there's a syndrome, board examinations like to ask about that. Now you may scroll through and look at one of these and say, gosh, there's a mitotic figure, that maybe it means it's a malignancy. Well, it doesn't mean it's a malignancy. Again, notice the lesion is relatively small, symmetrical. This probably punched out one of an entire lesion. And these may kind of occur in a systematized fashion. They may occur in an agglutinated fashion. So even though maybe you've sampled one papule of a group of lesions, it still doesn't mean that the entire plaque is malignant. But it's okay to get an occasional mitotic figure. You start seeing a lot of mitoses, maybe 5, 6, 7 or 8 in the lesion, or maybe there's 3 or 4 high power field. Even though the lesion looks like it's relatively small and symmetrical, you need to be sure that it's not evolving into a leiomyosarcoma in that situation. And we'll talk about that in a minute. We talk about an atypical Lyomyoma. Now this, in contrast to pilo or an erectile Lyomyoma, is a Angio Lipo. I'm going to show this central one, even though there's a large one off to the side, because it shows a nice example. Notice it's actually really and truly in this case is subcutaneous. It's down in beneath the dermis, so it's in the fat. They don't have to be. This one over here probably still in the fat, but maybe still impinging in the lower dermis. But you notice that it's a very small, symmetrical, well circumscribed neoplasm. Again, it's comprised of these cells that have the blunt cigar-shaped nuclei, like you see here. They're kind of these blunt, fat nuclei. And then they get some paranuclear apical vacuoles. Very common to see that in leiomyoma. And if you look at the Angio Lipo, you may actually see the little pre-existing vascular space like you see here. And notice the wall of this blood vessel probably was a muscular arteriole here. And then the hamartoma just developed possibly from the wall of this vessel or maybe another vessel and just led to this little nodular neoplasm. These lesions also can be painful, but the classic example of this lesion, I mean, and these clinically, usually dermatologists don't think about this lesion clinically. They're usually thought of as a cyst or some kind of subcutaneous nodule. Then they either take a punch of it or they may do an incision and it may actually shell out. So this lesion, like nexal tumors, they actually, when you do an incision over them, they can just kind of pop out. So that's a nucleation is another sign of a benign lesion in these, in a cutaneous lesion. This is a nice example showing all these blood vessels in the lesion. Usually don't see that many pre-existing normal blood vessels in an angioliomyoma, but you see a lot of those over here. And again, you might get an occasional mitotic figure, not many. And again, if you see the architectural features of a benign lesion like this, it's almost always just a benign process, nothing really to worry about. Now, this is a situation where you can kind of get into trouble. Again, we've talked about this many, many times in this conference, and hopefully when you go to sleep at night, you'll hear my voice saying, beware of taking shave biopsies of large soft tissue neoplasms. They can lead to erroneous diagnoses, sampling error. And this is an example of a so-called atypical leiomyoma. So it looks kind of like the first lesion that we saw. Notice that it's a little bit higher. But in higher magnification on this one, there's a lot of atypia. These cells now have some pleomorphism. The nuclei vary in size and shape. You might even see some scattered mitotic figures in this lesion. And so if you see something like this, these often get signed out as atypical leiomyoma. Now, is this actually a leiomyosarcoma? If you do have a shave biopsy of this lesion, it's hard to be sure about that, because if you have something that's much larger, asymmetrical, got this smooth muscle differentiation with all these pleomorphic cells, and you start noticing mitotic figures, well, then it probably is a leiomyosarcoma. If you just have some features like this, because these lesions have such a low-grade biologic behavior, even if they really and truly are leiomyosarcomas, as opposed to like an internal leiomyosarcoma, say in the uterus, or another location internally in the body, maybe from a GI tract, those lesions metastasize and they can kill the patient. In the skin, if you get a true bona fide leiomyosarcoma, they tend to have a very low-grade biologic behavior, even though they truly are malignant. So you want to excise those. You don't want to just leave them in there forever, because they can sometimes become more aggressive and then they can spread. But the vast majority of cutaneous leiomyosarcomas, luckily, behave in a very benign fashion. So even though they're cancers and they can spread, they almost never do. So if you're going to get a cancer or soft tissue malignancy, you probably want to get this one. But this would be an example of what we would probably call an atypical leiomyoma in a case like this, and we would recommend this lesion be completely excised. So relatively small lesion, seemingly, probably not as aggressive as a fully developed leiomyosarcoma, even though they tend to be relatively benign in the skin. But still, we would recommend excision of this nonetheless. And, maybe when you excise it, there's nothing left. And then you wouldn't necessarily need to upgrade the diagnosis to leiomyosarcoma. But just recognize that this is one of the lesions that can give you some atypical cells. And when it does, we don't just instantly call it a cancer. We call it this atypical variation. Now this, in contrast, again, is probably a punch. Might have been an incisional biopsy. So I think it actually was probably not just a punch. And notice that here we've got a diffuse process extending both to the sides and, kind of to near the base of the lesion here. So we don't know how broad symmetry, circumscription. As we go to higher magnification, we see this diffuse proliferation of these smooth muscle bundles. Once again, they're arranged in these fascicles that are kind of irregularly, haphazardly distributed. A lot of pleomorphic cells in here once again. And as we keep kind of scrolling around, here we've got a very atypical cells in here, and you might even see a mitotic figure over here. And if we keep looking, you might see a zone where there may be, say, 3 or 4 mitotic figures. So this was an example of a leiomyosarcoma. So this lesion was broader, larger, more diffuse, more atypical cells. It cytologically looks similar to the atypical leiomyoma, but it's a larger lesion with much more atypia, with more mitotic figures. So it's kind of on a spectrum. So when the lesions get, if it's a small lesion that looks like a leiomyoma and it's got these atypical features to it, well, then we call it just an atypical leiomyoma. If you start getting areas like this, where there's some really sheets of atypical cells with these pleomorphic nuclei and mitotic figures, well, then we start saying, well, now we're probably going to just upgrade it and call it a leiomyosarcoma. But once again, the good news is it's not really a super aggressive soft tissue tumor like a sarcoma or something like that. So just simple excision, follow-up is pretty much all that needs to be done in these patients. So basically, leiomyoma, atypical leiomyoma, leiomyosarcoma. That's the kind of the spectrum of that entity. A lot of lesions like this may actually arise from a pre-existing leiomyoma that's been there for many, many years and then undergoes malignant degeneration, sort of like adnexal tumors can sometimes undergo malignant degeneration. It's probably what's happening in this situation. Okay, so that's it for muscle. There's really only a few things you really need to know. There's a few other things that are in the family of the myofibroblastic tumors, cutaneous myofibroma, that's also got features of myofibroma, hemangiopericytoma-like morphology associated with those. That sort of falls in this spectrum, but that's pretty rare. Probably aren't going to see one of those in the board examination. But you probably will see a few potentially lesions of subcutaneous fat. Okay, so we're going to switch over to that. And first one of these you can see here is an example of a lipoma. Now, this is kind of an interesting variant of a lipoma. Notice that it's got a small, the individual, this might be actually one lesion that they just cut in kind of a bread loaf fashion. But you can see that it's a relatively small, symmetrical, well-circumscribed lesion comprised of normal fat here. These are normal lipocytes, nothing atypical about them at all, but it's kind of got this fibrous capsule to it that you can see here. And these lesions, when you look at them clinically, they actually look like subcutaneous little nodules. They're often thought to be cysts, and then the clinician does maybe an enucleation procedure again, trying to pop it out of there, and it does pop out, and it looks like this. And this is called a mobile encapsulated lipoma. So normally you see kind of the bag of worms, diffuse dermal process that you go in there and do an incision on and just kind of deliver it, if you will, out of the incision that you make with multiple lobules of yellowish fat coming out of there, or you can even do liposuction on it. This lesion, in contrast, actually comes out like a little marble, and it's called a mobile encapsulated lipoma. Nothing really special about it. It's just a variant of a lipoma. And again, notice the fat cells look normal. They're typical in appearance. There's nothing unusual about this lesion at all. It's just basically a variant of a lipoma. Okay. Another example of a fat tumor. This we just basically just call a garden variety lipoma. It looks kind of like the one we saw before. This one's got some dystrophic calcification over here. Again, probably what happened was the lesion got traumatized and then ended up getting some dystrophic calcification. So it's not a calcific lipoma or anything special. It's just basically another variant. So and just a normal neoplasm, normal subcutaneous fat, no atypical cells, no brown fat. This is just yellow fat, and just another example of a lipoma. Okay. This lesion, let's see, this is numbers case 7. Yeah. So this is also a variant of lipoma. Notice the fat over here. So these are normal fat cells. But then if you look to the side of these normal fat cells, you see all of these areas where there's abundant mucin. And there are about, probably 5 or 6 variants of lipomas. One is where you get abundant mucin, and then we call that a myxoid lipoma. And you can also get a spindle cell lipoma where there are a lot of spindle cells. And if you remember the normal anatomy of the fat, basically the lipocyte consists of the fat lipid droplet, if you will. And then you get the little sort of signet ring-like cells with mostly nucleus at the periphery. And those cells here can proliferate dramatically and have a lot of spindle cells to them. They can also acquire a lot of mucin in their cytoplasm, like you see here. And then you call that a myxoid lipoma. So if you get both spindle cells and a lot of mucin, they actually can kind of have an overlap between a spindle cell lipoma and a myxoid lipoma. So there's a lot of overlap between those two entities. But the key to the diagnosis is noticing the presence of the subcutaneous fat, the normal fat, in aggregation with the myxoid component. Now, if you just saw nothing but this, and you didn't see very many of the normal lipocytes, you would have a hard time making the diagnosis of a myxoid lipoma. It just could look like a cutaneous myxoma. But just realize that this is what the stroma, the myxoid stroma, looks like in a myxoid lipoma. You get the spindle-shaped cells, and these are probably fibroblasts, but they're also, some of them may be the nuclei of the lipocytes as well, with the abundant mucin. And anytime you get mucin anywhere in the body, you're always going to get some occasional mast cells associated with that in a large number of the cases. So don't be surprised if you're looking around these lesions, see some mast cells in there and say, oh my goodness, the guy has mastocytoma. Well, they don't. It's just normal mast cells that you see anytime there's abundant mucin in any kind of accumulation in the skin. You can see mast cells in there. So this is a myxoid lipoma. These lesions often present on the back of the neck of older individuals, men especially. They're thought to be lipomas or maybe thought to be some kind of a subcutaneous neoplasm. Nothing to worry about. It doesn't mean anything. It's just a variant of a lipoma, and you want to make sure that you don't overdiagnose these as say a liposarcoma. Now, we do have the liposarcoma at the very end we'll talk about, but one of the things that you sort of need as a sine qua non for the diagnosis of a liposarcoma is the presence of lipoblast. So if you don't see primitive lipoblast with atypical cells with mitoses and things like that, then it's almost never a liposarcoma. So we'll cover that in a minute when we get to that lesion. Okay. Sometimes you biopsy a lesion that's, again, this is in the family of the painful tumors. And notice here we've got a lot of normal fat, but admixed with that, we see these vascular areas with it. And it sort of looks like a lobular capillary proliferation without any inflammation to it. And this is an Angio Lipoma. And you can see variable amounts of the angio component with an Angio Lipoma. This one's got a lot. This one's almost 50% of the vascular component and the fat component. In some cases, you can see up to 90% or more, where there's just mostly the vascular component with only a small amount of the fat component. It looks a little different than a classic angioma. If you just saw this at higher magnification, say, you know what, that looks like a variation on the theme of an angioma, but it kind of almost looks like a cellular, almost an epithelioid angioma, if you will. It's got a slightly different morphology than a typical angioma. So it goes along part and parcel with the fat hamartomatous component of the lesion here. It's a little different than just a classic vascular lesion that just has fat associated with it. It's not really a collision tumor. It's actually a part of the lesion. I don't know why they develop together. We do know that there are blood vessels that run in the subcutaneous fat. Obviously, when your body starts breaking down the lipid and it gets into your bloodstream for energy purposes and whatnot, there are a lot of blood vessels there that are circulating and around all the individual lipocytes there. So this is just a situation where you get a hamartoma where they're increasing the number of lipocytes and also get an hamartomatous component of those blood vessels associated with it. So that's kind of the way this lesion develops. And even though this is in the list of your England, Bingle, whatever your mnemonic device is for the painful tumors of the skin, we see a lot of biopsies submitted to us just as lipoma, quote unquote, without any history of pain. So even though these lesions are listed in the painful tumor family, they don't have to be painful all the time. If they did, they would always be submitted to us as painful tumor, but they're just submitted to us in many cases as just plain old garden variety lipoma. Now this is really superficial lesion, and it's kind of hard to see this, but this is another example of a benign fat tumor that in this case, I'm going to try to circle that back for you here. Yeah, and they just kind of shave this. So this is a lesion that had fat hamartoma, but also cartilage here. So this was a ChondroLipoma, if you will. So it actually had both fat as well as some cartilage. Now, that's a relatively rare phenomenon, and it's actually been called also a mesenchyma, if you will, where you've got multiple different types of mesenchyme that are forming a tumor. So fat is mesenchymal, chondroid is mesenchymal. Could this have come from a myxoid lipoma that underwent chondroid differentiation? Possibly, but if it didn't, and it actually was a neoplasm that really and truly was a hamartoma, both of fat and cartilage, you have the possibility of Proteus syndrome in that situation. So that's the pearl about this slide, is that Proteus syndrome can give you these so-called mesenchymomas. So they get the abnormalities, the partial gigantism and soft tissue overgrowth, and occasionally you biopsy one of those, and it shows changes like this. So just realize that basically, if you get a neoplasm of fat plus cartilage, it can develop in a couple of different ways. It can actually be a true combination of fat and cartilage, or it could be a myxoid lipoma that's undergone cartilaginous metaplasia, cartilaginous differentiation. So that's just another interesting variant. And there are several other variants of subcutaneous neoplasms. There's a fibrolipoma. Again, we talked about spindle cell lipoma. We really didn't show that today, but just realize that that can look a lot like a myxoid lipoma. Now this, if you look at low magnification, looks like a skin tag. And if you looked at it in the clinic, in a patient, it might look like a giant skin tag also. But the thing that's different here is that you've got a ton of fat in this lesion, and notice that the fat is present prominently near the base of the specimen. There's also some looks like dermis or soft tissue or fibrosis in there, fibrous tissue formation as well. Then up in here, you've got all this fat that looks like it's present in the mid-reticular dermis here, which really shouldn't be there. In this example of a nevus lipomatosis, and the differential diagnosis of this is just a large skin tag with a lot of fat in it. A lot of times we see a person coming in with just a single papule on the chest, you biopsy it, and then it looks like this with fat, and it's just a skin tag with fat in it. But if you see people that have these multiple sort of cauliflower-like plaque-like areas, usually on the buttock or the hip area, sometimes the upper thigh, well, then this histology would be consistent with a nevus lipomatosis. And so I tend to be less liberal about making the diagnosis of nevus lipomatosis. It really kind of needs to have that clinical appearance because there's so many just large fibroepithelial tumors that have abundant fat in them that really aren't nevus lipomatosis. It doesn't really make a lot of difference, but just if you're a purist, probably better to really reserve the diagnosis for nevus lipomatosis when it really kind of has that plaque-like morphology or looks like a stalk with a kind of a cauliflower-like surface to it. So this would be consistent with the diagnosis of a nevus lipomatosis. Okay. All right, the next one we're going to look at, and the reason that this one's kind of near and dear to my heart, because I remember this was the first slide on my derm board examination that I took way back in 1985. They used to give us a tray of slides that we had to look at and then pass them off to our neighbor. I think today everything is digitized, but back in the old days, they actually would give us a tray of slides. And so I remember looking at this and I said, interesting. It's a neoplasm that's got all this brown fat in it. And the reason this is brown fat, the cells kind of look like little vacuoles within them. This is probably a normal lipocyte over here without any real brown fat in it. But this is the brown fat that you see in neonates, usually between the scapula and mid back. And all of these fat cells here, if you actually look under the microscope, electron microscope, you can see that it contains abundant mitochondria. And if you really need to get your fat cells release the energy that's in them quickly to your body. If you're a little baby, that you get cold really fast, you don't want to get hypothermic, well, you need brown fat there. And so this is a example of a neoplasm benign of brown fat. It's a hibernoma. And so this was the first slide that I had on my exam years ago. And I said, wow, this is maybe going to be an interesting exam because they've got a nice example of a hibernoma as our first slide. Well, the second slide was molluscum. And I said, well, that's not very challenging. I mean, here I've been studying for this exam for a year and going to review courses and spending hours taking notes and studying, and you kind of insult my intelligence by putting a molluscum contagiosum that a high school student could diagnose. So not everything that they test you on the board examination is challenging. So there's just remember, the good news is you'll get some gimmies on there, and hopefully this will be a gimme too, because if you can recognize this as brown fat, you can make the diagnosis with certainty. So it's basically just a benign neoplasm of brown fat, and it's not malignant. I guess there's probably maybe cases reported in the world's literature. I've never seen a hibernoma that was malignant. I just haven't ever seen it. It's not that it theoretically couldn't happen, but most of these are usually seen in younger individuals, and I've never seen one cancerous. Okay. This one, actually, I said we didn't have a spindle cell lipoma. Well, I was wrong. We actually do have one. This is what this is. This is a spindle cell lipoma. And you'll notice here that there's a lot of mucin. So it looks a lot like the mucin, the myxoid lipoma that we saw before. How do we know that it's not just basically a spindle cell neoplasm with mucin, like some kind of a myxoid, spindle cell neoplasm of another sort? Well, we got the fat here. So once again, that's helpful if you see that there's areas of well-differentiated fat in the lesion, impinging on areas where there's more spindle cell proliferation. And then this lesion also has got some myxoid area as well. So this is a nice example. It kind of shows you the spectrum where you can get myxoid lipoma changes, as well as other areas where there's more spindle cells. So just like we talked about the Lyomyoma being kind of a spectrum between regular garden variety Lyomyoma and atypical Lyomyoma and leiomyosarcoma. Well, here we've got a myxoid lipoma, we got normal lipoma, myxoid lipoma, spindle cell lipoma. And then sometimes you can actually get liposarcoma, which we'll show in the next slide. But this is the myxoid area, and this is the more spindle cell area over here where there's less myxoid component. So again, there's a lot of overlap between spindle cell lipoma and myxoid lipoma. So just make sure that you know these variants of lipomas. And you're probably not going to get a lot of questions about this on the board examination. This is really more soft tissue pathology and dermatopathology, but you should at least know what a myxoid lipoma is and know how to distinguish it from a myxoid liposarcoma, which is going to have a lot of atypia, a lot of mitotic figures, lipoblast. This just is a normal variant of a lipoma. I'd be surprised if they actually show you something like that on the exam, but just be prepared just in case. This last one is a true garden variety liposarcoma. Now, there's several different types of liposarcomas. Just so you'll know, the soft tissue pathologists are always looking to rename things. Years ago, they used to call a lot of these soft tissue neoplasms subcutaneous fat that had spindle cells, like you see here. They were frankly atypical with mitotic figures and whatnot in them. They would call a lot of these liposarcomas. Well, then they moved away from that to call them malignant fibrous histiocytoma. I think there's kind of a move back to call some of these now liposarcomas today. But in any event, just realize that you can get malignancy occurring in the subcutaneous fat as well. And these usually are large, giant lesions in the skin clinically. They don't look like a typical lipoma when they often look like a large, huge plaque that's maybe got an area that looks like a bruise or a lot of blood vessels within it. And if you just take a small biopsy, this was a relatively small biopsy, you may not actually even hit the diagnostic area, because you really need to, these things can be biphasic. You can have areas that look less aggressive than other areas. So you really need to see areas where there are a lot of spindle cells, where there's mitoses, and then you need to see lipoblast. Now, what is a lipoblast? Let me see if I can find a good one for you. A lipoblast is a cell that's got a little area of lipid within it, and kind of a signet ring type morphology where the nucleus is kind of off to the side of it. And you really kind of need to see those in order to make a definitive diagnosis of a liposarcoma. So we're going to look over here, and you can see that there are these very atypical cells here. Notice they vary in size and shape. Let's see, this is probably a lipoblast here. We've got this kind of signet ring kind of morphology to it with a little bit of a lipid in the center of it. This is probably another one over here. So these are very pleomorphic cells. There's a lot of atypicality, and there are probably some mitotic figures in here. Now, one caveat that I'll mention, there's one variant of a lipoma known as a pleomorphic lipoma, where you get these pleomorphic cells like this. It can be hyperchromatic nuclei, they can have multiple nuclei, and they can still be benign. So in order to really make the diagnosis, this is a nice lipoblast right here. The pleomorphic nucleus at the side with the lipid in the cytoplasm right over here. This is a beautiful example of a lipoblast right here. There's another one over here. So if you see lipoblasts like that with these pleomorphic cells, and you get mitoses, and it's asymmetrical, and it's got the other features, that's really almost, it's diagnostic really of a liposarcoma when you see that. Now, if you don't see there's a number of lipoblast, you don't see the mitoses and things of that nature, it can be a pleomorphic lipoma. But in this case, you've got these lipoblasts, and you've got these sort of almost myxoid areas off to the side, and then these pleomorphic areas. So this was an example of a liposarcoma. And again, unlikely to get quizzed on this. There are a number of different other variants of liposarcoma. There's a round cell liposarcoma. There's a spindle cell liposarcoma. There's a pleomorphic liposarcoma. There's a dedifferentiated atypical liposarcoma. There's about 5 or 6 in the literature. And the more atypical and pleomorphic and poorly differentiated they are, obviously the worse the prognosis. So just realize that for liposarcoma, you really need the architectural features of malignancy plus lipoblast plus atypical cells and mitoses to make that diagnosis. So that's it for a survey of neoplasms of smooth muscle and fat. There are other soft tissue things that you should know a little bit about: cartilage, fibrous tissue. I think we may talk about some of those in the coming weeks. So just make sure that you have a general understanding of these lesions. Again, this isn't something that you're going to be quizzed on in the same level of intensity, say as a dermatopathologist would on a board examination, or certainly a soft tissue pathologist, but just understand these general neoplasms and the main criteria for diagnosing these. So again, thanks for your attention, and we will see you next week.